Hey everyone, let's dive right into this explainer. We often tend to think of medicine and health as this hard, universal science, right? But when it comes to the mind, man, the cultural environment you're born into changes absolutely everything about how you experience distress and, more importantly, how you heal.
So to start us off, ask yourself this. What if your mental health diagnosis depended entirely on your zip code, literally where you live? Is what we consider normal a universal biological truth, or is it just a localized cultural habit? The research we're looking at today proves that while mental distress itself is a universal human experience, the way it's actually felt, interpreted, and treated, totally 100% dependent on culture.
To really wrap our heads around this, we've got to redefine what we mean by culture. It's not just, art, language, or food. Think of it more as an invisible rulebook. It's a category of information and behavior made up of shared objects, preferences, and meanings. It literally dictates our everyday behaviors and, wild enough, even our internal distress. It shapes how our minds break down and how they put themselves back together.
Which brings us to our first major concept, defining normal. Let's see how the baseline for a healthy mind actually gets established across different societies.
I love this quote from researcher Martin Seligman. He says, "Normality means average." That is such a crucial point. Normality in psychology isn't some absolute universal standard handed down from the heavens. It's literally just the arithmetic mean of a specific society's behavior. Whether someone is deemed mentally healthy is decided by the everyday norms of their own specific country. Basically, what's normal for you is just whatever the people around you happen to be doing.
And here's a brilliant example of how entirely opposite behaviors can be considered perfectly healthy depending on your local average. Take British culture on the left. A dry, maybe understated sense of humor is celebrated. It's a sign of sharpness and well-being. But jump over to Indian culture on the right, and researchers note that super blunt, direct comments are often seen as the highest form of praise and honesty. If you judge one population by the psychological standards of the other, you might accidentally misdiagnose an entire nation. Not right is completely relative across borders.
All right, let's move into our next section, experiencing distress. How does this cultural baseline actually change the way diseases are physically and mentally felt? Just look at this staggering number, 300 million. According to the World Health Organization, 300 million people globally suffer from major depressive disorder. It's a leading cause of disability, a massive social and economic burden, and it severely messes with educational, occupational, and psychological areas of life. But here's the million-dollar question. Does everyone experience this massive burden the exact same way? Well, the research says absolutely not.
The exact same disease manifests totally differently depending on where you're standing. For instance, Western outpatients often emphasize affective and emotional symptoms, feeling sad, guilty, or losing pleasure in things. But Chinese outpatients experiencing that exact same clinical depression report it with a much stronger emphasis on existential and cognitive dysfunction, or even physical somatic aches. So the concept of depression doesn't always line up with Western clinical definitions. It might be interpreted as a moral problem or a reaction to a social stressor. Same underlying condition, entirely different cultural vocabularies.
We actually see this exact same thing with social anxiety too. You really have to ask, is the illness a fear of failing as an individual or a fear of disrupting your community? In Western cultures, social anxiety is frequently characterized by this intense fear of public speaking or bombing an individual performance. But in many Asian cultures, it shows up as shyness and avoidance specifically to protect group harmony. It's a fear of causing offense or disrupting the collective, rather than, say, a fear of personal embarrassment.
So, because the symptoms and expressions differ so wildly, it makes perfect sense that the coping mechanisms and care models have to be vastly different as well. Let's explore coping, East versus West.
This table breaks down these fascinating divides. It really shows how a culture's core values dictate its entire approach to mental health. Take a look at Japan. The core values there are harmony and self-inhibition. Because of that, communication is indirect, and outward emotional expression is often viewed as disruptive. Contrast that with the United States, right? Driven by individualism and autonomy, where talk therapy, direct emotional disclosure, and focusing on the self are basically the gold standard. And then look at India, where values of spirituality and holistic growth lead to a focus on community support, family partnership, and concepts like Dharma. It's three completely different pathways to healing.
The real takeaway here is that in many Asian cultures, outward emotional expression is often viewed as a disruption of interpersonal harmony, or even a sign of weakness. In those contexts, people are way more likely to just down-regulate emotional disclosure. Engaging in hobbies, exercising, or just hanging out with family, passively watching TV, those are seen as highly effective coping mechanisms, which means if you blindly import Western talk therapy, where you're forced to sit in a room and verbally vent your negative feelings, it might actually be highly distressing and completely counterproductive in a collectivistic culture. Actually, scratch that. It wouldn't just be counterproductive, it could be genuinely harmful.
But hey, treatments aren't static. They move, they adapt, and they evolve. Let's move to our next section, the journey of mindfulness, and see how practices can successfully migrate across the globe.
Just look at the timeline of mindfulness here. It is so fascinating. It transforms from this ancient Eastern spiritual practice into a highly secularized Western clinical tool. It kicks off in the 6th century BCE with Buddhist introspective roots in India, using a concept to cultivate present-centered awareness to free oneself from suffering. Fast forward to the 1930s, and Japanese-American homes and restaurants in California unknowingly start introducing elements of these practices via specific tea rituals. Then, boom, the 1960s hit, and John Kabat-Zinn deliberately adapts mindfulness into a secular clinical stress reduction program in the West. He stripped away the religious narrative to make it an objective medical tool. It's a brilliant example of how a psychological tool can be culturally translated.
Now, translating practices is one thing, but what happens when we hit the barrier of language itself? Let's take a look at the language of mental health.
I want you to consider this mind-bending quote from David Schweitzer's 1977 study of the Xhosa people. He noted, "For most of the hunter-gatherers studied, madness is not conceptually distinct from sadness. No lexical or experiential equivalents of the concept were discovered." Think about that for a second. If a language literally doesn't have a distinct word for madness, does the illness even exist there in the way Westerners understand it? If a Western psychologist assessed them through a Western lens, they would completely miss the reality of their lived experience. It's wild.
Because of the severe language gap, trying to deliver global care is incredibly complex. In places like Nepal, establishing mental health care requires this intense chain of translation. Step 1, an English-speaking mental health professional trains an interpreter. Step 2, that interpreter has to somehow translate really complex, culturally specific diagnostic concepts like psychosis into a local language that doesn't even have a word for it. And finally, Step 3, lay health workers use these newly formed local terms to treat patients. Because diagnosis relies so heavily on assessing speech and emotions, literal translations of Western terms often fail miserably. If just one link in this chain breaks, the whole treatment fails.
All of this brings us to a really critical crossroads for the future of global mental health governance. Let's look at our final section, the future of global care.
Right now, the global community is weighing two highly divergent approaches. On the left, we have Scenario 1, growing similarity. This is the push for a universal, one-size-fits-all diagnostic system worldwide, a global standard applied to everyone everywhere. The risk here, of course, is imposing Western psychiatric models inappropriately on the rest of the world. Then, on the right, there's Scenario 2, embracing diversity. This means rejecting ethnocentric tools and instead developing localized, culture-specific instruments for every unique population. It's the big debate. Do we strive for one universal medical standard, or do we fully lean into localized, diverse care?
Researchers consistently note that if we want to avoid health disparities, we absolutely have to build deep cultural competence. And true cultural competence goes way beyond just running things through Google Translate. It requires deeply understanding a community's language. It means respecting local religions and structural worldviews. It has to account for daily habits, gender roles, and even varying attitudes toward authority. A lot of these differences are incredibly subtle and super easy to overlook. You just can't drop a Western clinic into a rural Indian village and expect it to work without understanding the cultural soil you're planting it in.
So I'm going to leave you with this provocative question to ponder. If normal is really just the average behavior of our own specific culture, how will we choose to define well-being tomorrow? Knowing what we know now about how deeply our environment shapes our minds, how should we design the future of human health? Should we try to make everyone the exact same, or should we learn to heal people exactly where they are? Thanks so much for joining me on this explainer. Keep questioning what you consider normal, and I'll catch you next time.